So good morning, everyone. And I myself, Dr. Sunil Gupta, the National President of Diabetes in Pregnancy Study Group of India, welcome you all for this very important public awareness initiative of DIPSI, which we have started on 30th or 31st of January this year. And we have already finished the first cycle of covering all national languages of India, and we have covered it in different languages. Started with Punjabi and ended with even Awadhi and Bihari language and the Rajasthani Marwar language, and everything practically we have covered except one. And we welcome you all for this public awareness initiative. Basic purpose of this meeting is to make people, women aware and the family aware about importance of diabetes in pregnancy, and why it is important that every woman should know about it. I feel every one of you know that some women gets pregnant, and then you go to a gynecologist and they go for some basic test, and everyone knows that we now test for hemoglobin. Everyone knows that we test for the blood group. Someone educated person also know that we take care of the antiretrovirus and VDRL test. All these tests are being commonly done in the blood when you go to a gynecologist for the first time. But very few of the women, they are aware that pregnancy diabetes is one of the very important area where every woman should be made aware of, that every fifth or fourth woman in the country who's pregnant might have some kind of high blood glucose in pregnancy. And that is why awareness on this is at most important. We want, if DIPSI, basically DIPSI's aim is that every woman, every family should know that there is an entity which is called as pregnancy diabetes or gestational diabetes, and this needs to be aggressively addressed for diagnosis, that's screening, for treatment, and the follow-up of these women in future, and the child's and the offspring, or a child who born to this mother in future. So with this basic concept, that if you really want to prevent diabetes in our community in future for next generations, if you want that after 20 years, 30 years, your future generation should be protected from developing non-communicable diseases like diabetes or obesity or coronary artery disease or hypertension, we have to work hard when the baby is in the womb. And that's called as primordial prevention of the disease before the baby is coming out in this world. And with this concept of DIPSI, which has been founded by none other than Professor Dr. V. Seshaya. Dr. Seshaya is the founder, president, and the patron of DIPSI. And he has recently been honored with Padma Shri Award and in 2022. And it is his vision that we are working together across the country from various platforms. And this is on different languages. We are doing this diabetes PregaTalk. Today is the language, which is English. And we have 4 eminent faculties here, which I would like to introduce here. We have very senior endocrinologist and professor and head of department of endocrinology from Delhi, and the past president of DIPSI, past president of RSSDI, and Dr. S.V. Madhu. Sir, we welcome you for Diabetes DIPSI PregaTalk. He's always very much aggressive and supportive in making people aware in this part of the country, whether it's diabetes, whether it's endocrinology, whether it's osteoporosis, whether it's vitamin D, any part. When it comes to public awareness, Dr. S.V. Madhu always have a strong support and strong proponent of making people aware of any non-communicable disease like this. Then we have.
Thank you, and good evening to all.
Thank you, sir. We welcome you. We have none other than a person to whom you get very difficult to be catch hold. He's too busy and extremely busy in the academic work, his practice, and his social and academic commitments. And the founder, general secretary of DIPSI, Dr. V. Balaji. Dr. V. Balaji, if you Google any of the article in India, diabetes and pregnancy article in India, and first few 10, 20, 30 papers will be coming only on the name of Dr. Balaji and his center, along with Dr. Seshaya and the team from Chennai. And rest of the papers will come after all these papers are gone. So first page of the Google, if you see diabetes and pregnancy research paper in India, is going to be from Dr. Balaji and his team. And he is a founder secretary of DIPSI, and very strong support and very strong pillar of this organization, which is doing wonderful job in last 3 decades, almost 4 decades, under the umbrella of Professor Shaya, and Dr. Balaji is one of the strong hand. Sir, we welcome you for this particular meeting today, and he's a director of the center in Chennai. We have just got the entry of none other than very senior obstetrician gynecologists and the ICOG chair of India, the national chairperson of ICOG, Indian College of Obstetric and Gynec, Dr. Uday Thanawala, who's again a governing council member of DIPSI, and is very active member of the Dipsy family. Rather, is one of the strong support in this part of the country. Rather, when it comes to any national consensus making statements on diabetes in pregnancy, gestational diabetes, Dr. Uday Thanawala is always on the forefront of promoting the Government of India guidelines, the making people aware. And let me share with you, just less than 12 hours, less than 10 hours or 8 hours, he has been requested, sir, evening you have to be there with us. And Dr. S.V. Madi was requested yesterday evening, late night rather, and both of them are available. I'm really thankful to you, sir, and Dipsy will be really thankful to you forever for your unconditional support for this social cause. We welcome you, Dr. Uday Thanawala, and
Thank
we
you so much,
have.
Sunil.
Thank you, sir.
Thank you
And
very much, and always for you, anything. Bye.
thank you very much, sir. And then we have none other than Cheryl Sellis. Cheryl Sellis, I can call her as my younger sister, and she is one of the celebrity dietitian of the country, and has keen interest in public awareness. She is attached to, because I'll go little personal with Cheryl, because Cheryl is attached to Kavita madam very very closely, and both of them are working very hard to bring up the education in public in type 1 diabetics especially, as well as other common people in this part of the country when it comes to Western India. Not only she is based at Mumbai, and she's from the Nurture Health Solution, but she is one of the she's a RD, registered dietitian, and Cheryl Sellis is also holding big post in national IDA, and she's always very supportive to our family of Hello Diabetes, and she's a part of Hello Diabetes always, since almost last 10 years or a decade or so. So we welcome you, Cheryl, for this meeting on public awareness on diabetes and pregnancy today. With this introduction, let me now start the session, and I take this honor and opportunity to ask the first question to Dr. S.V. Madhu. Dr. Madhu, sir, we have completed our Punjabi, then Telugu, Tamil, and recently we have completed Gujarati and Hindi, a lot of programs, and Malayalam and everything, up to Kashmiri, Dogri, everywhere, and we are trying to reach to people across all the corners of the country. But why Dipsy want that public should know about GDM? Of course, I gave you little brief in the introduction, but we would like to understand from you why it is so much important that every woman in this country of the childbearing age, and even if it's not childbearing age, at least the subsequent generation, if you want to be protected, for every family by that matter, should be aware of this particular ailment, and why and how and why it is important for us in future. Over to you, Dr. Madhu.
Thank you, Dr. Sunil Gupta. And firstly, I need to compliment you and commend you for this tremendous initiative to see that there's a public awareness of the need to understand diabetes in pregnancy all over the country and in all different languages. I think that's a laudable effort. And having said that, and coming to your question, as you put it in the beginning itself, I think every person in India, not only the pregnant woman, should be aware that pregnancy, the diabetes in pregnancy is, or hyperglycemia in pregnancy, or high blood glucose in pregnancy is an entity which we all need to understand, and its importance is far-reaching, not just for the sake of complications in the mother and the child during the pregnancy and the delivery, but because of its long-term consequences in terms of the occurrence of diabetes and NCDs no much after this pregnancy is over in the next generation, for example. In a way, diabetes in pregnancy could be setting the tone for the diabetes epidemic in this country and world over. And its primarily responsible for this transgenerational transmission of diabetes, as we call it. And for the general public, diabetes is indirectly spreading from the mother to the child, and the child grows up, becomes a diabetic. And if there's a lady who is again gets pregnant, is a diabetic, so the cycle goes on and on and on. And therefore, pregnancy diabetes is a wonderful opportunity for all of us, for not only for the treating physicians, the obstetricians, but also the patient herself. Not the patient, I would say she's not a patient in that sense, but to contribute to her own health, health of her offspring, the children, and the health of the community and the country at large. So therefore, in other words, hyperglycemia or diabetes in pregnancy, most of which is gestational diabetes, which means you recognize the condition only in pregnancy first, is has immediate consequences for the mother, because it has several implications. Like, the mother may have a bad labor, may have cesarean sections, may have several other complications, hemorrhage after a pregnancy, stillbirth, and so many other issues. And the child also that is born could be having several problems, including intrauterine death, abortions. You could have malformations in the child, and you could have so many other issues in the child itself at the time of delivery or even preterm. So these are the immediate worries for which the lady has to know about this condition, and so that she can manage her sugars well, she can manage the pregnancy well, in contact with the team of physicians, obstetricians. So it works. But more importantly, the diabetes that is there, the GDM or the pregnancy diabetes, is a very great or important risk factor for future diabetes in the offspring, or even in the lady herself. She may not have been diabetic for the pregnancy, but if she has diabetes detected in pregnancy, then there's a very huge chance that post pregnancy she will sooner or later become a type 2 diabetic, and therefore may require long term management of her diabetes. So therefore, not only the immediate risk in terms of pregnancy complications, long term risk in terms of diabetes NCDs in the mother herself or and offspring, and therefore we all need to work together to understand this condition, and to see that the not only pregnancy diabetes is prevented, but diabetes as a whole in the country is prevented.
So very nicely narrated, Dr. Ashri Madhu, and a very important message. He has said clearly there are two kinds of diabetes in pregnancy. One which appears in pregnancy and might disappear almost in 85% of the cases after delivery. Another one, those who are already having type 1 diabetes or type 2 diabetes and they want to become pregnant. Third could be they are not aware of their pre-existing diabetes and have been detected to have diabetes for the first time when the screening during pregnancy was done. So there are three different classes which are existing in the society or in the patient, and their treatment, of course, the one who's pre-existing type 1 or type 2 diabetes, he has beautifully said that we have to control diabetes well, else there is a risk of congenital malformations and mishaps which are going to happen, which we'll cover with Dr. Uday Thanawala and Dr. Balaji in future. So pre-existing diabetes, becoming pregnant. Few diabetics were being detected during screening. Then they were not aware, but it is actually pre-existing diabetes. But during pregnancy, they have tested the blood and it came to be 250 and 300, and HbA1c is high. And third, typically appearing in pregnancy and disappearing after delivery, usually after second or third trimester, but sometimes even the first trimester. So let me go to the pioneer person who's working since almost 3 decades in this field, Dr. V. Balaji. Dr. Balaji, now we know the importance of gestational diabetes, and we know that there are government of India guidelines which are very much established and which need to be followed across the country. What so can you how can you just enumerate how best our people with diabetes, people in the family, every woman in the family or every family member in the society should be knowing about the screening? How do they screen? Like how should we get the test done? How should they diagnose it? And then we will go for management part little later. Over to Dr. Balaji on the diagnostic criteria, which have been actually laid down by Dr. Balaji and his group.
Thank you, Dr. Sunil Gupta. First, I appreciate you for your commendable work in this public domain. And I'm very happy that you're taking a keen interest in this public awareness program. Hats off to you. So when we come now, I think Dr. Madhu spoke about the importance of GDM. And so knowing that South Asians and Asians are very highly susceptible, in other words, epidemiologically, if you see, we have 11% more chances. South Asians are more ethnically susceptible. So we wanted to make sure that all our pregnant women get tested and all of them should be screened for diabetes during pregnancy. You know about our country's economy, and it should be easily doable, and it should have both a single test which can be made as a diagnostic, as well as you can be able to pick up people and they should not be asked to come again and again. So the DIPSI first, what it says is make sure that almost all pregnant women are tested for diabetes in pregnancy or gestational diabetes. So two, what happens is in a country like India where you don't get a lot of people coming in the fasting state, and you know during pregnancy a lot of taboo during pregnancy, they should not be fasting, they should not be allowed to fast for a long time. So we thought of a test that's a DIPSI criteria, a single test which can able to diagnose and treat gestational diabetes. That is the non-fasting test, a fasting or non-fasting test where you do a single test. So when the patient comes in the fasting or non-fasting, you give them 75 grams of glucose and a plasma glucose greater than 140, we put them as gestational diabetes. So this is very simple, economical, and again I'm repeating, see, don't please send people away because they are not in the fasting state. So this test works in the fasting as well as in the non-fasting state. So if anybody is there, even if they have come in the non-fasting state, give them 75 grams of glucose, do a post-glucose test, and 2 hours you see the blood test. If it is more than 140, they will be looked into for GDM. So this is very easily doable even in the communities and places where the socio-economic conditions are not very good. So this is a test which has also been endorsed by WHO. It has been endorsed by FIGO. It is endorsed by the IDF also, and the DIPSI. This is called as the DIPSI single test for diagnostic and screening.
Yeah. Thank you, Dr. Balaji. And then during this test, they should not, the two important thing that they should not be going for exercise or anything during these 2 hours after taking the glucose. They can sit and they should not smoke. These are two important messages while doing the test, but it is easily doable and everyone can do it. And in the clinic, when you're waiting for a doctor, you can just do it, sit for 2 hours and get the report done. But don't go to the mall which is beside the hospital and roam around and go for shopping. Don't do that. That's the only message for every woman while doing this test. Let me go to Dr. Uday Thanawala now. Dr. Uday, sir, you are a very senior and esteemed person in the field of obstetrician gynecology in this part of the country, rather across the country, being a chairperson of ICOG. Now we know the importance of GTM. We also know that how do we diagnose it. We have diagnosed it, and now you have done this test. Now you know someone has come with 160 blood glucose, and you also possibly have done HbA1c, which is one of the tests which gives you average blood sugar, which is not for diagnosis but at least for prognostic marker. You have a well established center, not necessarily to be done in every clinic or in the rural places where not facility is not available, but some cases you might do it. So what will be the first step? Will you go for metformin? Will you go for therapy or diet, and then we'll go to dietitian once she is connected? Yeah, Dr.
So,
Uday.
Sunil, thank you for this. And it's as everybody has said, you're doing great work in bringing this public awareness. Now, one thing which I do when any patient comes with abnormal sugar is I spend 10 minutes first with the patient. And I explain to them whatever Dr. Madhu has said, that, this is high sugar in your blood. This high sugar in the blood is going to go through the baby, and this sugar is not good for the baby. It is somewhat toxic to the baby, this sugar level. So you need to keep the sugar level normal. If you do that, the baby will not have any of the side effects which Dr. Madhu has said, like the baby becoming very big in size or the metabolism changing, and the difficulty in deliveries, etc., will not happen. And most importantly, like he pointed out, this baby's pancreas will not get programmed in the uterus, so that this baby will not become future diabetic in their lives. Now, when this woman understands the complexity of GDM or what that sugar is going to do to her baby, then she takes it upon herself to control it in a very good way. And we have to tell her one very important thing, that the pregnancy values are different than what values a regular diabetic patient, what your mother or father or husband has. Those levels are different. In pregnancy, we want the fasting sugar to be less than 90, and we want the 2 hour post meal sugar to be less than 120. And if you achieve this in a regular baby in a regular fashion throughout the pregnancy, then your pregnancy will be uneventful. It will be as good as a pregnancy, normal pregnancy, without having any sign of diabetes. So once, spend those 10 minutes with the woman. The woman should know exactly what she's dealing with, and it's important. That is the only thing which will make them control the sugar. Now, to control the sugar, the first step, now suppose you said the value is 160, the first step which I will probably do is, I'll tell her, look, if she can afford it, and today it's very affordable to buy a glucometer and do the readings yourself at home. So what is known as self monitoring of blood sugar. So I tell them, you do at least 4 to 5 readings in a day for 1 week. We must know what your sugar levels are. At the same time, start the diet control and start the exercise. So I'm sure diet control, our dietitian will tell us. But as far as exercise is concerned, I am surprised most of the women really don't are not in a habit of doing any exercise at all. So you have to start small steps. You say, okay, at least start walking. And the best thing is that after every meal, walk for at least 10 to 15 minutes by the clock, morning, afternoon, and night after dinner. Utna, do that much. Otherwise, you can go out and have half an hour walk or something. And they need to inculcate this habit of diet and exercise into their lifestyle, because whatever you say, the diabetes goes away, etc., etc., ultimately it's a lifestyle change for them. It will prevent them after the pregnancy to uh, prevent them from getting diabetes if they keep things in order. So what we do is we monitor the blood sugar, tell them to self monitor the blood sugar, or if you can't do that in some settings where it is not possible, you tell them, okay, 10 days you do, this is the diet which you take, this is the exercise which you do, and after about 10 days, get your fasting and post lunch done from a laboratory. Now, it is to be very careful to tell them just do a fasting and your post lunch 2 hour reading, because many women then take glucose again, which is not done. It's not supposed to be done. You just do a fasting and post lunch and see what the values are. If the values are still high, then one thinks of starting a therapy. And the commonest therapy which most women prefer is the oral anti-diabetic drugs. And but if the sugar is not being controlled by that also, then one can think of insulin oral, which I'm sure you'll come to a little later. But basically, they also have to be told that if you don't get it under control, one tablet will is there which will control your sugar. So but try your best, because if she's in the screening stage of 26 weeks or 25 weeks, you can afford to have those 10-15 days. So that is what it is. Do you want me to elaborate a little more?
Yeah, I feel very well said, that one should first you diagnose it, then start with counseling. Then you can start with lifestyle modification, where diet will be taken care, but then exercise is the most important. Very simple message, that after your meal you can just walk for 10 or 15 minutes, maybe 2 or 3 times in a day. That's good enough. So at least 20 to 30 minutes walk. Simple walk will also help you taking care of this insulin resistance which is occurring in a woman. And while monitoring, yes, not only the fasting blood sugar and the post meal, we should also know that it is post breakfast. He said he should be monitoring 4 or 5 times a day for a week. So what are these 4 or 5 times? Post breakfasting, post breakfast, post lunch 2 hours, and at least post dinner 2 hours. If you are not on any drug, at least for some day you monitor it, and then you can have a staggering method, that someday you monitor these two, next day you monitor another two, and then next day you monitor another two, like this. Then you can do it if your blood sugars are very well controlled. Usually in pregnancy, gestational diabetes, fasting will remain low and lower side if it is pure gestational diabetes, and they may present to you with postprandial high blood sugar. And to control this postprandial high blood sugar, we have none other than Cheryl for medical nutrition therapy. Cheryl, can you just highlight a few important points, because our women, the moment they come to know that it is diabetes in pregnancy, they get highly depressed because they presume that being pregnant is a license to eat everything, and each and every those things which are not good for otherwise, they want that it should be taken for. And sometimes they take it for that I'm carrying my baby, so I have to eat for two. So all these things need to be removed from the mind of these women. So over to you, Cheryl.
Right, sir. Good evening, everybody, and good morning, sir. And I think we've had a very interesting discussion from all the faculties, and nutrition plays a very, very important role. And I think come pregnancy, and like you said, everybody thinks that this is the time that I don't have to worry about fitting into certain clothes and I can eat. And there's a lot of pressure from the family as well. So when GDM strikes again, they get extremely concerned because then a lot of foods have to be, basically the diet again becomes one of the most important cornerstones in management of gestational diabetes. And most often our patients are managed on lifestyle and diet alone. So one is emphasizing on importance of eating adequate nutrition, because what we also see is that they're very scared of food, and that is why they end up eating very little, and that is also not right. So we have to give them the right advice in terms of eating a balanced nutritious diet so that they get all their nutrients, not going very, very low on calories, because otherwise they will end up with starvation ketosis. They will not get the right nutrition. And again, emphasizing on moderation in carb, because again, our population eats a lot of carbs, comes breakfast, lunch, dinner, bedtime. The amount of carbohydrates that they consume is very high. And we know that in gestational diabetes, the post breakfast blood glucose levels are the most difficult to control. And that is why moderating the carbs, splitting the carbs at breakfast. So we usually tell them to start with something which is a low glycemic index, low glycemic load food. If they eat eggs, we encourage them to have eggs or nuts, as well as like a pulse based breakfast like a chilla or a pudla. And focusing again on importance of eating the right amount of protein, because again in the first trimester the calorie requirements they don't differ, but the second and the third trimester there is a need to increase the amount of calories, there is a need to increase the amount of protein. So plus 9.5 grams of protein in the second trimester and plus 22 grams of protein in the third trimester. And again, our population is deficient in their protein intake. I think they all know food, they don't understand carb, protein and fat. So we have to encourage them to eat protein with every meal, because that also helps to blunt the post glycemic blood glucose response, because post meal sugars are always a challenge in these patients. So also giving them satiety, as well as giving them good healthy fats, especially omega-3 fats, adding fiber to the diet. So for example, if we ask them to have a chilla in the morning, we ask them to add buttermilk to the batter. We tell them to grate vegetables so that they get some amount of protein, they get fiber, and it becomes a very wholesome nutritious meal. So similarly, we give them recipes of breakfast options, snack options, and so making it very easy and less stressful for them, easy for them to comply, and hand holding them. So I think through the entire pregnancy journey we become their friends, and we are always with them right from the time of diagnosis till even delivery and post delivery, because again nutrition, as and all of you do emphasize that nutrition plays a very, very important role, and that increases her confidence and her trust in a nutritionist. And this is how we would try and because as I've seen today we have a lot of people, thanks to social media, WhatsApp, they are encouraged to give up carbs completely. A lot of people come to us and say, should I stop eating carbs? And this is becoming a very common thing, and we tell them that especially in pregnancy it's very important not to go very low on carbs, because they have been already doing say 50 grams of carbs a day or 20 grams of carb per day. They are on very low carb diets even before. So then we have to tell them that even if you look at the NI and ICMR guidelines, they very clearly state that you need to give at least 175 grams of carbs, because this is important for the fetal brain development. But of course we will give good quality carbs. So I think the whole emphasis was on trying to get diet diversity, trying to ensure that every nutrient that they eat or every calorie that they eat is nutrient dense, and giving them the right nutrition definitely for them and to achieve good, healthy pregnancy outcomes.
Yeah.
And nuts, we try and add that. Then even again fruit placement, because otherwise they keep eating a lot of fruits even with their meals, and we see that the post meal blood glucose levels go high. So when do we eat the fruit, how much of the fruit to eat? All these become very important aspects of counseling of this mother, with focus on good fats coming from your nuts and seeds.
Cheryl very rightly said that you have both the extremes available available with you. One of the person woman will come to you is too much afraid of taking meal and she might starve herself, and the other one who might not give value to Dr. Balaji or Dr. Uday or Dr. Astri Madhu as well as me, and will go on eating whatever. No, the mother-in-law will say, "Don't worry about doctor to bolte rehta hai, will go on eating," and they might not bother about it. In both the situations, you have to balance everything.
Right,
And
sir.
importantly, very important message is that that pregnancy is not a condition where you should be one should be trying to reduce obesity or the management of obesity or something like this, but a
Right.
nutritious food. And you can reduce the calories to some extent if they have obese women, maybe around 300 or 500 calories if they are literally obese with high BMI. But then most of the women are being managed, in a very balanced way. But
Right, sir.
Cheryl, we also have, our women have sweet tooth, and then Kavita always enters into one recommendation whether we should have artificial sweeteners. Gynecologists, they don't want to give any artificial sweeteners. Many of the physicians have their own reservation, including me, to avoid it. But recommendation says that some of the artificial sweeteners are safe and they can be taken in moderation. So, any your final word on this, Cheryl?
Right. So, so evidence has, I mean, if you look at, the recommendations, sucralose and stevia are considered to be safe in pregnancy. However, we try and see, because sometimes there can be an overuse also of it, So, very important is to counsel them, and we can give them other healthier options which can help to address those sweet cravings. So, we can give them certain healthier options which they can have, post, like making something like a fruit parfait as a snack, or making something which is not requiring actually the addition of a sweetener, but still trying to help them address their cravings for sweet. So again, we work with them and give them recipes on how we can do that. But if you look at the the recommendations, like you rightly said, stevia and sucralose are considered to be safe, but again within the ADI limits is what we usually will tell them, sir.
Yeah, so fair enough. And of course, the frequent small meals will certainly cut
Right,
down
sir.
the postprandial spikes which are seen, especially in
Correct.
gestational
So, I
diabetes.
very rightly said, I mean, it's been discussed here that post meal walking, and I think this is something we always encourage them, because physical activity, and they always feel that if they have diabetes, it's like a disease state, and they believe that they should take rest and not do, unless it is, obviously told by the doctor that they should be not do any physical activity. We encourage them to do that. And I think post meal, we ask them to ensure that they do some amount of walking around, even in the house, which will help them to keep their post meals under control.
Very good, Cheryl. And so 70% out of 10 GDMs, 7 will be taken care by Cheryl and Uday directly. And Dr. S.V. Madhu and Balaji and myself will be out of the picture for some time, except for monitoring. Then Uday will call me up, Sunil, my blood sugar is normal now. So should I do anything? I said to continue, sir. Whenever it is required, when you require any additional therapy, we will go to Dr. Madhu and Dr. Balaji. So let me now ask this question to Dr. Madhu, because I have got a phone call from him that he has to rush up little bit some patient emergency. So Dr. S.V. Madhu, I'll come to Dr. Balaji for insulin therapy. I'll directly jump to preconception counseling and care, because we are talking about gestational diabetes, but we should certainly give some importance. Rather, it's very, very important for pre-gestational diabetes or pre-existing type 1 diabetes or type 2 diabetes or planning their pregnancies. And how should we be going for preconception counseling? What is its importance? What are drugs we should be avoiding? And what are the other evaluation? In short, we always say every woman with type 1 or type 2 non-diabetes should get conceived only after the permission of their diabetologist or endocrinologist. And nowadays, I started calling Dr. Balaji it as fitness for, like you have fitness for surgery or fitness for pregnancy. So that fitness for pregnancy should be written by one of us, so that the lady is safe in all from all the corners, which includes your glycemic control, proper drugs, insulin therapy, evaluation of your micro and macroangiopathy, and then making her fit for it. Over to Dr. S. Madhu.
Yeah, thank you, Sunil. I think this is a very important area. We had focused on GDM or pregnancy first, I mean, diabetes detected first in pregnancy, but ladies who are already a known diabetic, especially type 1s, who wish to get pregnant, I think that's a very important section of the women who, with hyperglycemia and pregnancy, which we need to address. And as you rightly said, the management of these patients actually starts much before pregnancy. Once they get pregnant and they get into an unplanned pregnancy, there are lots of challenges both for the physician as well as for the pregnant lady herself. And it's a tough time getting things under control, although they will get eventually under control. But there is a big role of what we describe as pre-pregnancy counseling. And I think, as you rightly put it, fitness for pregnancy, and I wish it is true, because that is a dream of all endocrinologists and diabetologists, that all diabetic patients, type 1 or type 2, actually get their sugars under control adequately as declared by the treating physician, and only then get pregnant. But it's so far it doesn't happen most of the times. And I think this is a very important platform from which we should convey to the general public and all those diabetic patients or diabetic girls or young ladies who wish to get pregnant, that you must get your sugars under control and fully under control, and almost a normal HbA1c, as we say, before you plan a pregnancy. And if you do all this, and the doctor, the treating physician, can ensure or assure you that your pregnancy will be as normal as a non-diabetic pregnancy. Therefore, it's hugely important that you follow this simple advice. If you are a diabetic, please get your sugars under control first, and only then plan the pregnancy, and everything will go very smoothly. That's number one. Now, second issue which he was referring to also is, what about complications of diabetes? I mean, how should we address the complication issue if somebody is planning a pregnancy? I think that's a very important area again, because it has been seen that a pregnancy sometimes can lead to worsening of complications, particularly the eye complications and sometimes the kidney complications, and therefore it is always essential that you screen for your retinopathy or the eye complications and the kidney complications, and make sure that they are stable, well under control. If any treatment is required pre-pregnancy, that is done right at that stage, and so that your pregnancy remains uneventful and you safe, and you're able to deliver a healthy baby and you remain healthy as well. That's the pregnant mother. This is the second thing. Then, of course, the drugs. As far as possible, you avoid all possible drugs when you want to plan pregnancy for any indication, unless they're absolutely essential. In terms of anti-diabetic agents, again, the ideal situation would be that you're off all drugs and you actually get controlled on insulin. But there are situations when people do get pregnant on metformin, and then and even the guidelines say that it's okay if somebody takes metformin. But ideal would be that you get your sugars in control with insulin, get a normal blood glucose value and normal HbA1c, then become pregnant, and then hope for the best. And why hope for the best? You will actually get the best if you do all this.
Yeah, Dr. Madhu, but the unfortunate part is that 90% of the pregnant women, they come to you and they say, "Saab galti se ho gaya," and this
That's what I
galti
was
se.
saying. It's a dream. It's a dream of a diabetologist and endocrinologist that they actually undergo all this pre-pregnancy counseling and that gets their sugars into control. I wish that day comes after such public awareness programs.
Yeah, and Dr. Balaji is also, no, Dr. Uday is raising his
Yeah,
hand. But
I
before
just
that,
wanted to say
yeah, can I just
one.
acha, okay, Dr. Uday, your comments, yeah.
Yeah, sorry. One step ahead from what Dr. Madhu has said when you come to preconceptional. Yes, when we are talking about diabetics who are under your care or a physician's care or someone's care, they have to be told that yes, get your sugars under control, get your HbA1c below 6 before you try a pregnancy. What I'm trying to say is, in a public forum, it is very important to tell all the women that when you even become pregnant, please, when you visit the doctor for the first time, if the doctor hasn't written a DIPSI test for you or a sugar screening test, please get it done. Remind the doctor that you need to do, because that screening test of DIPSI, which Dr. Balaji has said, it has to be on the first contact and on at 26 weeks. So when we're educating the women, the general public now must be so aware that they say कि हाँ मेरा hemoglobin चाहिए, मेरा sugar चाहिए, or this thing though has to be done even when they go to the doctor for the first time. So this just to take that preconceptional screening a little further.
Dr.
Sorry.
Madhu has to leave, Dr. Uday. So I'll just ask him the last question in maybe 30 seconds. Comment on the polycystic ovarian disease and gestational diabetes and the care on these lines. Dr. Madhu.
Yeah, polycystic
Very
ovarian
common
disease.
nowadays. We have a lot of women who are, a lot of girls who are obese.
Yeah,
Which is just very common phenomena now.
it's very common, and although and they require several types of treatment for pregnancy. Their fertility is otherwise low in many patients, and therefore they do get pregnant on certain medications. And one of the important medications, anti-diabetic medication metformin, is used for treating PCO and help them conceive. And there are situations which are not uncommon where on metformin the lady gets pregnant. So the guidelines, different guidelines have different takes on these, whether you should continue them throughout pregnancy or stop the metformin once you detect them. But in general, since the DIPSI guidelines say that metformin is an option, and if somebody is controlled and well controlled on metformin, you could continue the metformin also, and wherever the targets are not reached, add insulin or change to insulin. That is one thing that I thought I will say. There are others who say that it's better to shift them to insulin once you detect them, but by and large, sugars which are well controlled on metformin, even in a PCO who gets pregnant, who is detected diabetic later on or has been a mild diabetic earlier, you can continue the metformin also for the sugar control. Rest of the things, as far as the management of the pregnancy, would remain the same. Even in the case of PCO, ideal situation would be that the patient, the lady is in touch with the physicians and the obstetrician gynecologist, and has things under control fully before actually a pregnancy is planned. But many times, because they have difficulty in conceiving, this conception happens, and the ladies conceive, and you need to continue whatever they're taking unless sugars are higher or detected to be high, and then you need to change.
Thank you very much, Dr. S. V. Madhu. I feel with the permission of Dr. Balaji and Dr. Uday and Sheryl, Dr. S. V. Madhu wants to he has some other commitment with this. Let's give a big hand for his contribution to DIPSI. So DIPSI is thankful to you for this contribution. Thank you very much for being with us.
Thank you
Now,
all.
thank you, sir.
Thank you.
Thank you, sir.
Now, may I ask the question, go back to Dr. Balaji on insulin therapy. Sir, we left with Dr. Uday Thanawala on metformin, as well as Dr. Madhu also highlighted on metformin. Insulin remains the drug of choice across the board, across all the recommendations. Would like to have some word, because the moment you say insulin, in our experience, Dr. Balaji, most of the women, when you advise insulin, compliance is much better when they are versus the non-pregnant women versus pregnancy. So they do accept it, provided we give the importance in a proper manner. But what are the contraindications? What are the of metformin, where it should be given absolute indication of insulin? All these things. Over to you, Dr. Balaji. You have got some original work on insulin therapy and in diabetes and
Yeah.
pregnancy, also in GDM. Yes.
Thank you. Thank you, Dr. Sunil. So first thing, let me put it across a little bit on screening, which you have to complete. So the public should not think that you screen them once and then if they are normal, they should be left alone. They should be screened almost at every trimester. The DIPSI studies have shown if you have not screened them first and now the first time when they are screened, they are negative, 28% subsequently in later trimester become positive. So screening should be done at almost every trimester to make sure they develop gestational diabetes. Now coming to gestational diabetes management, as the nutritionist very aptly said about medical nutrition therapy, if the medical nutrition therapy fails and the blood sugars hovering fasting over 90 or 2 hours, post breakfast over 120 or postprandial over 120, then the choice of using medications come. So medications means we have two major medications which are in use. One will be insulin, the other is metformin. So the advantages of insulin, if you ask me, is it's the only drug which does not cross the placenta. So once it does not cross the placenta, harming the child, absolutely there is no problem. Whereas metformin use, it can be used, it is used, but it is crossing the placenta. Long-term effects we are not sure. Short-term effects are very, very good. So when we talk about insulin, if you're talking about GDM, true GDM, that means I think a small dose of insulin starting at 3 to 4 units a day, maybe to control the post breakfast, should be ideal. And supposing if the patient refuses, they want to be put on metformin, they can be put on metformin. But if the sugar is not under control, insulin has to be added. So the blood sugar has to be maintained between 90 and 120, especially with insulin. If you ask me about contraindications, I don't think there is any contraindication to insulin unless they develop hypersensitivity to insulin, which is very, very rare. Otherwise, using insulin, and again, it's based on the merits of the patient. Supposing you're dealing with the type 1 patients who are coming and marching into pregnancy, or type 2 diabetic patients marching into pregnancy, the requirement can be very high based on insulin resistance. But if you're going to deal with the true GDM patients who are diagnosed around the later weeks of pregnancy, then the usual insulin requirement is very, very low. Again, you have the designer insulins or the insulin analogs, which have already done studies and said it was safe. The advantage of these insulin analogs is it can be used immediately after a meal or just before a meal, so that even if the patient vomits, then this will not be a problem when you take a regular insulin 30 minutes before a meal. So insulin, I will say, is maybe the choice of the patient, but we have to explain to them why we are using insulin, because the moment when we talk to the patients or that we have to start insulin, they think we are harming them or giving something which is not good for their body. So we have to tell them it's a natural replacement. It does not cross a placenta and it's very safe for the baby. And then subsequently, if they do not agree or they do not want insulin after counseling, then maybe we can go for metformin and then or a combination of insulin and metformin.
Thank you, Dr. Balaji. So, and as the pregnancy advances, as the pregnancy progresses, the insulin requirement may go up from the second
Yes.
trimester, third trimester, third trimester to till delivery. It may go up, except in the last 1 week of 1 or 2 weeks of delivery. We need to go on increasing the dose of insulin as the insulin resistance increases. Your blood sugar monitoring, you should do it regularly, and can go ahead with. Dr. Uday Thanawala. Now we have finished with the pharmacotherapy diet. Now over to you on how should we be having monitoring the fetal surveillance. Many of the couples, they have a concern that a lot of investigations are done, especially sonologists, and sonography is being done very, very frequently. So starting from the first trimester at the time of diagnosis of pregnancy till delivery, in very, very brief way, which weeks we are supposed to monitor the fetal well-being, and then last part will be about the delivery. Over to Dr. Uday Thanawala.
So the first investigation, which is very important, is when they first contact you and the first visit itself. And most of the women come after missing their periods at 6 or 7 weeks. One needs to do a sonography to confirm that the pregnancy is growing in the uterus and there is a definitely viable pregnancy growing. So in general, the first scan is done at around 7 to 8 weeks. But even if they miss that, it is not a problem if they're all okay. The most important sonography which is done is now between 12 to 14 weeks of pregnancy, which is the what we call as the NT scan. NT scan is the nuchal thickness scan, where we see the full structure of the child, because by this time everything, the head, the legs, the arms, the heart, everything is developed, and we try to see it in great detail to rule out any abnormalities. And we see the thickness of the skin fold behind the neck, which gives us some indication whether the baby could have a problem inside, like Down syndrome, etc. And that is a important sonography between 12 to 14 weeks, because if the patient is not sure of her dates, etc., whatever due date you get from this sonography is the most accurate, because we are measuring the fetus when the fetus is still small. So that is the important sonography which we do, to the 12 to 14 week scan. After that, generally an Amelie scan is done. Means now the heart is growing, the brain is growing. In general, all the structures we have seen, but at 20 weeks, we get a very good visualization of all the structures, including the brain and the heart. And we do a proper fetal echo. Fetal echo means we see the heart in great detail, because diabetics who become pregnant, they are more prone to have a heart defect in the baby. So these people have to get their heart scanned, preferably by a fetal medicine person or a radiologist, to see if the heart is normal, and that is between 20 to 22 weeks. Once all this baby's anatomy is proven to be normal, and then we come to the growth scans, which happen generally after 26 to 28 weeks. And in general, in diabetics, we do it once a month. And in normal pregnancies, we can even delay it to once in 2 months. But in diabetics, we prefer to do it once a month for two, three reasons. One is because sometimes these diabetic patients are a little obese, and it's difficult to clinically only judge, how the uterus is growing or how big the uterus is. Second important thing is there are certain types, if the sugar is abnormal, then certain signs will appear on sonography, like the volume of the water, the liquor, what we call the water which is surrounding the baby, that is becoming more. So then you know that there's something wrong. Redo the sugars again. Do we have a correct answer? Is the sugar under control? Or the abdominal circumference, the baby puts on more weight or more fat around the abdomen. And if that is more than the period of gestation, that means the baby is getting affected by a high sugar load which is coming from the mother. So to see these signs, we do more frequent sonographies in a patient who conceives. So we generally do it between 26 to 28 weeks, then we do it at 32 weeks, and of course at 36 weeks. At 36 weeks, the other important parameter which comes into is the baby's health. So we do the even Doppler studies, whether the blood supply to the baby is fine, the blood supply around the body is fine, and all those things. So these are the main scans which are done, for growth. And sometimes if you pick up an abnormality, then more frequent sonography will be required. If you pick up some Doppler abnormalities, more frequent sonographies may be required. So that is about the sonography part, what you are asking. And as for the blood investigations, what Dr. Balaji has already said is the DIPSI test is repeated from the first trimester, again at 26 to 28 weeks, and preferably at 32 weeks in the third trimester, to rule out that there's no sugar abnormality. Many practitioners would do that third trimester test only if they pick up a sign on sonography. But generally, the DIPSI recommendation is do it once in every trimester. Beyond that, we do the infection screen, etc. We also do the Downs syndrome screening test at 11 to 12 weeks, which is a different parameters. We see certain markers which tell us whether this pregnancy or this baby is more prone to have Down syndrome. And it is important when the blood is sent for this, we mention on the paper that the patient is a diabetic, because the values what we see for change, and they have to apply a correction factor. So all these blood tests are routinely done, and that is how the pregnancy progresses. And if everything is normal and the growth is normal, then in generally we let the patient progress to full term. And if the sugars are remaining normal, then we don't mind the patient going to the full term of 40 weeks. But if the sugars are not very well controlled, or if the patient is on insulin specially, then either we interfere when there is a sign of fetal distress by either the Doppler study or the non-stress test, which we subject these women to after 34 weeks. But then one can interfere earlier. But in general, Sunil, when we talk about diabetics, especially who are on either metformin and especially on insulin, we as obstetricians tend to prefer to deliver them between 38 and 39 weeks, and not let them go right till 40 weeks, and certainly not beyond 40 weeks, because we have found that sometimes there are sorry, incidences of sudden stillbirths. So we are scared of that, and we generally would prefer to induce our patients or deliver them after 38 weeks whenever it is easy or possible to do it, especially depending upon how our sugars are controlled, how the baby is growing. If the baby is grossly affected, then we may do it much earlier also, depending on what the situation is. It's all individualized. But in general, if the sugars are very well controlled, we treat it like a normal pregnancy, let the patient progress on its own. But if the sugars are not very controlled, then we want to interfere at around 37 to 38 weeks. 38 weeks.
So that misconcept the general people have about that all women, once you are labeled or once you are stamped to be a GDM, then Caesar is must. I feel that is a misconception, and very rightly you
No,
said.
yeah, that's a misconception. It all depends upon what is the baby weight, what is the preparation of the cervix, whether the mouth of the uterus is inducible, and whether we can easily induce it or not, and all those things, and the baby's health, of course.
Yeah.
And if there's any
So now,
cephalopelvic precaution.
so
Because you must
today we have.
remember, these babies are big, so babies are big. So many of them do go for a Caesar, but because of these various problems which occur. But otherwise, there's no harm in giving them or trying for a normal delivery.
So if your blood sugar remains uncontrolled, throughout, or maybe even in parts, then there is a high risk of having bigger size baby. Bigger size baby does not mean that they're healthy baby. Anyone who is more than 3.5 kg baby at the time of birth is suggestive of an uncontrolled diabetes in past, since you are diagnosed to have gestational diabetes. And that's why we should try to keep the baby between 2.5 to 3.5 kg at the time of birth, so as there is less risk of developing diabetes in the adult life in such babies. So now we started with the importance of GDM, then screening, the diagnosed, then we have treated the lady. We have wonderfully treated, the given the diet by Cheryl. Everything is being done. Baby got delivered through Dr. Uday Thanawala, available
So
here. Now we come to yeah, Uday, you want to say
yeah,
something more?
be very one has to be very clear that if your diabetes is not under control and you have any of these complications like a bigger baby, polyhypertension or something like that, please, especially if your sugars are not under control, deliver in a center where they have an NICU attached, because this baby will not be able to maintain its sugar outside, and the baby may require glucose drips and frequent monitoring of sugar, which is better done in an NICU. So if the facilities are there, deliver these patients or get delivered in a place which has got an NICU, so that the baby can be looked after very well.
And we should try to keep the blood glucose between 70 to 120 at the time of delivery, intrapartum period.
Yeah,
If they are,
yeah,
especially when they are not only on diet therapy, they will be maintained on this. But if they're on insulin therapy or even sometimes high dose of oral drugs, they might land up with high blood sugar. And there, if the blood sugar remain uncontrolled at the time of delivery, there is a high risk of having hypoglycemia in these
hypoglycemia.
babies at the time of birth, which is very, very important part. So now intrapartum management, sometimes we need to go for insulin infusion. Dr. Balaji will agree with me. I'm not going to go in detail of it for the sake of time as well as public, because it's more of an intensive care monitoring of and management. But let us now, baby got delivered, and I was told by the staff in the hospital where all four of us are working, that this out of 100 GDM who delivered, 15 remained glucose intolerant. Blood sugar is still high, though they were diagnosed, but they had diabetes and they were on therapy. This is one case, and the second case is 85% of them, they are become fully normal within 48 hours or within 24 hours after the delivery. So how should we have a follow-up of these women? Because Dr. Madhu has said, Dr. Uday has said that these women are likely to develop diabetes in next 5 to 15 years, almost 50% chances. So what are the strategies and importance of breastfeeding? So these are three important points. Dr. Balaji, over to you. And then we'll go for laddu, which are being given postnatal, to Cheryl, whether these laddus which are given to all women after delivery or in the lactation period, the importance of it, and then we'll go for the final concluding remarks. Over to Dr. Balaji.
Yeah, the most important part is the postpartum follow-up. See, these people are very empowered during pregnancy. The moment the baby is delivered, they feel everything is over and they're normal. Especially if they're GDM people, most of them become normal after delivery. But what they should be told is they have more than 50 to 70% chance of becoming type 2 diabetes in the future. So it doesn't go with that. Even their diabetes becomes normal after delivery. They are very high risk individual prone to develop type 2 diabetes. Which some places is difficult, some places it's easy. So what we sometimes do is we use the immunization program where they bring the child very often and use that for checking the mother also. So this is very, very, at least once in 6 months, there should be a GTT done on them if possible, and then to
Ajam.
identify whether they're type 2 or whether they are IGT or IFGs. So the most important thing for the mother after delivery is they can become type 2 much later. So they have to be followed up and the nutritional guidelines given, and they to tell them not to become obese, because after delivery in lactation they are made to eat a lot because they have to feed two people. So the diet restrictions, and also secondly, if you see,
I feel Dr. Balaji has lost the connection. May I go to Cheryl? Cheryl, for your diet during lactation, and the traditional ladus which are being given across the country with different names in the postnatal phase and the postnatal I still, on a lighter side, Dr. Uday and Cheryl will agree with me. Before the marriage, most of the girls, they try to maintain their weight, and they try to, at the time they should look good when they're being on the there as on a stage. Now, but most of these women after first delivery, the weight gain becomes one of the postnatal weight gain is very important problem. And these are the women who are likely to become GDM again. These are the women who are likely to become diabetes in future. So recurrence of GDM, future diabetes, this is very, very important area where nutrition plays a major role. Dr. Balaji could join now. Dr. Balaji,
Yeah.
over to you. You finish. Yeah, please.
Yeah, that is very, very important now. As I told you, the follow-up of mothers, which have been not easy till delivery, they are ready to listen to you. Whatever you say, they want to deliver a good baby. The moment the baby is delivered, they feel that their problem is solved and they're not bothered about themselves. They're only bothered about looking after the baby. So it's very important that we take care of the mothers and we have to give them information and try to empower them to come for regular follow-up. Or even if they develop type 2 diabetes after delivery, they should be told to follow the reticulous meal plan and then maybe medications depending on the level of blood sugar. So postpartum follow-up of GDM mothers is very, very important, and later even follow-up of the offsprings in later life becomes very, very important.
Yes. Over to Cheryl now. The diet during pregnancy, the
Yeah.
lactation, sorry, not pregnancy, lactation. Yeah.
Yeah, sure. So as Dr. Balaji rightly said, and even you mentioned that during pregnancy, they're the most compliant clients because they're so worried about the baby. But once the delivery happens, then, they just let loose and they just start going on because there's a lot of pressure. I think in India, we also have the in-laws and the parents and a lot of other people putting pressure that they have to eat more because then they have to feed the baby. So the whole focus is on getting adequate breastfeed for the baby, and this becomes the biggest focus. So very important is, I think, counseling, because like we've discussed that these women are at a higher chance of developing diabetes in the near future. So I think counseling post delivery becomes very important. Even if you look at caloric requirements, it goes up by around 500 calories, but again through healthy nutritious foods that we can give. So emphasizing on the right intake of whole grains, pulses, millets, vegetables, fruits, nuts and seeds. And when we're looking at certain foods, the laddu is a very popular thing given in our country, but we do tell them that you have this before you feed the baby. So very important is because lactation itself is a very high energy expenditure, process. So basically, we tell them you have it like a snack before you feed the baby. Ensure you even have adequate water, and make sure you're also a little bit active. After try and walk or try and find some time in between the day where you are going to be a little more physically active. Foods, you don't need to finish that 15 kilos of ghee ka dabba, which there's a lot of pressure that comes in from the family. So I think it becomes for us as nutritionists, we are actually dealing with the mother-in-law and with the mother, because they say that we ate it, and we have to tell them that things have changed today. And while it is not necessary to completely avoid, but everything in moderation is what we would encourage. And again, counseling during the lactation, and they're having regular follow up with this lady, calling them, which is very difficult for them to come. They don't see you after they've gone home, and this becomes a challenge. I think, doing telephonic calls and following up with them, asking them how they are. And I think this is the most important thing, to at least prolong the onset of diabetes. If not prevent it, if we can prevent it, great, but at least prolong the onset of type 2 diabetes.
And these ladus are Cheryl, so tasty that all husband, they also become little
Yeah.
overweight and obese. You know, uh, but
So
this
we
is very,
tell
very
them
important.
how to make it. So basically, we tell them, good recipes
Yes.
on how to make it without adding too much of sugar and, too much of ghee. So this is something. So now I think, all dietitians will agree with me. Every patient, first thing they want is recipes from us, So the first thing is like, okay, give me a recipe of it. And people are
And
getting a little more aware.
since 6 8 months, 6 8 months, Dr. Balaji has not allowed them to eat even a single sweet there. So all this 6 8 month ka pura backlog they wanted to have at the time of after delivery. So that is another important thing, Cheryl. Uh, uh,
That
uh, can I just ask Dr. Uday Thanawala to to give few words, 30-second message on breastfeeding, how much duration they should continue, and what are the advantages of breastfeeding to these women who have GDM or PGDM. And
Breastfeeding is
of
very.
course, yeah, Cheryl indirectly has said that you should be having something to eat before you breastfeed, because the risk of hypoglycemia increases after breastfeeding. So these few important key carry-home messages from Uday.
So breastfeeding is extremely important for the mother in this case to get her sugars back to normal in a very fast and efficient way. Breastfeeding helps her to do that. To get her sugars normal. It's very good thing to do. For the baby, though, it's extremely important because that is what is giving all the nutrients to the baby. And for the first 6 months, we advise the patient to do exclusive breastfeeding. Only breastfeeding to the baby for the first 6 months, and then we switch over and introduce the weaning and the process of weaning, etc., to the baby. But the woman has to breastfeed at least for 6 months. It helps her to get the sugars very well under control. It helps the baby to get the proper nutrition during the first 6 months of life. So first 6 months breastfeeding is extremely important and should not be neglected at all. It is also somewhat helping in contraception, but it's not a foolproof thing. So after 2 or 3 months, all the women who are breastfeeding also, they have to be careful and not have unprotected sex, because after 2 or 3 months, anytime the egg can release, and even before she gets her first period, we've had women who conceive. So
Yes.
contraception is another thing which they have to take care of, and especially if you've had GDM, etc., and if your sugars are not normal, you have to be very sure and plan your family in such a way that you have enough gap between them. Your sugar should be under control before you conceive next, etc., etc. So all those contraception is another thing which they have to think about once they deliver and go from the nursing home, and of course breastfeeding is encouraged through and through.
And longer is the breastfeeding duration, more is the
Normally for
chances.
2 years, normally for one and
More,
a half to 2 years, they breastfeed, but first
yes.
6 months is exclusive.
So and if it is longer the duration, better is the protection to the mother for developing metabolic syndrome
Yeah.
in their
Yes.
future life. So they are protected from obesity, as well as there is some
Right.
benefits to the baby. So
Correct.
these are some very important messages to every one of us who are listening to this particular talk. Now before we conclude, let me have one line or two lines final messages from all the faculties one by one. May I start with Dr. Balaji is a general secretary, should be speaking only at the end. So I'll start with Cheryl, then Uday, and then Dr. Balaji. Cheryl, the
Yeah, I would
final
like
message
to
to
say
all
that though
women.
pregnancy is a very beautiful phase and one of the most, beautiful phases in a woman's life, and if GDM strikes, again, not to get scared, we can manage it very well with lifestyle management, a balanced, wholesome diet, and do consult a qualified dietitian so that she makes sure that you're getting the right nourishment and you're also enjoying the entire pregnancy process.
Over to Dr. Uday.
So all the women must be aware now that whenever they get pregnant, blood sugar is a very important aspect of pregnancy, which they have to keep it under control. And the only way they can know is by doing a proper screening test, which is the DIPSI test. So they must ask the doctors that you have to know, and they have to get the DIPSI test done in the first trimester, in the second trimester, and the third. And in case it turns out to be abnormal, one has to bring out changes so that the baby is protected and they are protected in the future. We have
Yeah, it's the
enumerated it.
Government of India guidelines, not only DIPSI
Yes.
test. The Government of India has endorsed it, 2014, 2018, two guidelines. Yeah, so everyone should follow it compulsorily. Over to Dr. Balaji.
Yeah, and let me inform the public the basic summarizing that ethnically Indian women are more prone for gestational diabetes. So early screening is definitely needed in the Indian context. Early screening, then repeat screening, and then once it is diagnosed as GDM, kindly follow medical nutritional therapy and then followed by insulin or metformin. And postpartum follow-up of mothers and the child. So this is exactly what Dipsy is telling you, what we have been speaking so far. So please, let all of you should know there's an entity called gestational diabetes, which should be treated, and it should prevent the intergeneration transmission of diabetes.
Thank you very much. I feel DIPSI has also come out with a simple statement which has come in Hindi. Dr. Balaji, एक जान से बचे दो जान. with single test you can save two lives. The two generations are being protected. So ek jaan se bache do jaan. So never ever forget any woman who's getting pregnant, who's planning pregnancy, any woman who is nearby your place, your house, your neighbor, anyone who's pregnant should be screened for gestational diabetes also, along with other tests which your OBGY obstetrician is telling you. But never ever forget to screen yourself or your colleague who's pregnant for diabetes. If you miss it, you will be missing a big opportunity of saving the future generation. The child who's likely to develop diabetes in future can be protected from there here onwards, when the baby is intrauterine in very early stage. So first, the screening has to be emphasized. Every one of you, even if someone forgets it, you should make them remind that, doctor, please also get my sugar done. I know the dipsy test and that 75-gram glucose, should I get it done? And that permission should take and get it done. Don't just do urine sugar, it has no value. Don't just do post meal blood sugar, it has no value. If you're not subjecting yourself to a glucose challenge, you will be missing gestational diabetes. And please, 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 don't just see the lab reports, which most of the women, they see it from when they come from the lab, because in the lab report sometimes up to 160 170 they might write it as normal, 180 they'll say abnormal. Or and for pregnancy the targets are different. And that is why you should follow these guidelines. Do the test, and don't compare with your mother-in-law or the father-in-law who's at your home, or father, where you say 180 is okay, doctor, chalta hai. So it is not going to be chalta hai in diabetes in pregnancy. It has to be 90 and 120. So these figures has to be remembered very, very well. And with these few words, I feel I'll feel my duty to thank all my faculties, Dr. S. V. Madhu, Dr. V. Balaji, Dr. Uday Thanawala, Cheryl Celis, and every one of you who are attending this particular meeting. We are really happy to have. And let me also share with you, those who have heard and those who have got the link with them. This link will remain alive forever till we remove it from the social media. It's going to be there available. Same link is there. Those who have missed some of the part, they can listen to these stalwarts. I'm telling you repeatedly, it is at most difficult and impossible sometimes to get these luminaries on such platform together, including all 3-4 faculties and dietitian. And we are fortunate, the DIPSI is fortunate enough to get everyone together here for their dedicated work. Thank you very much. See you soon. Wish you very, very happy season's greeting, forthcoming Navratra, the Dashera, and then Diwali, and the Happy New Year. And we will very soon meeting with Dr. Balaji, Dr. Uday. Every one of us will be meeting in Chennai, maybe next week, the first week of October, for second of October at Chennai for the national meeting. With these few words, I declare that the session is over and close this session. Thank you very much.
Thank you very much, sir.
Thank you.
Thank you.